Hello, I'm Nisreen. I'm one of the exam candidates today and I am ready for the discussion.
Okay, have you read the scenario?
Yes.
Okay, so what data from the history do you want to ask about?
So, first of all, I introduce myself for the patient by my name and role, and I will confirm her personal details in terms of her name and date of birth. And then I will ask about her current complaint regarding her urgency and frequency of urine, since how long she has been experiencing these symptoms, and whether she has any leaking, like urgent, like when she has any urge incontinence, or what happened if she cough, sneeze, and laugh, like in terms of stress incontinence, and also whether she has been diagnosed previously with recurrent urinary tract infection or any problems in her urine, whether she feels any pain during the filling of her bladder or during passing urine, and whether she's noticed any change in the color of her urine or any, like, blood or anything like that. So after that, I'd like to ask her about her gynae history, whether she's sexually active and any problems with the intercourse. What about her smear history? What about her, like, if she has been diagnosed with any pelvic infection or sexually transmitted infection? And also whether she feel any lump or any, like, prolapse coming from down below. I'd like also to ask her about her bowel symptoms, whether she has any chronic constipation or anything related to her bowel. Then I'll ask about her obstetric history, how many pregnancies, and also about her deliveries, about if she is having any difficult deliveries or any instrumental deliveries, or any problems before related to her water work after deliveries. And then I will ask her about her medical history, if she's medically fit and well, or if she's taking any medication, including medication for hypertension or diabetes. And also I need to ask about if she's asthmatic, or if she is having any chronic obstructive lung disease causing her to have chronic cough that also may affect her symptoms. And also I need to ask about her allergies. I need to ask about her social history, whether she has any support at home, and what's her job, and whether this affecting her social life. And also, what about her smoking, alcohol drinking, and recreational drug use. I'd like to ask about any previous surgical history in her tummy or from down below.
Well, she's power free, normal deliveries, she doesn't have any urine leaks, she's medically fit and well, and she has had no previous surgeries. She's sexually active with no problems, no prolapse, and no bowel problems.
Well, so in that case, I need to do some investigations.
What investigations do you want to do?
So the first thing, I need to take her urine sample and do urine dipstick.
Why do you want to take a urine dipstick? She already has a negative culture.
Yes, I know that she has a midstream urine culture, which didn't show any growth. However, the urine dipstick doesn't only investigate for infection. It can also investigate for ketones, glucose, protein, and bloods in urine. So I need to know.
Well, what are you gonna do if you find blood in her urine?
So if I find the blood in her urine, then I need to refer her for a cystoscopy, just to exclude any bladder pathology, or like in cases of interstitial cystitis or any bladder tumors or anything.
Okay, well, she doesn't have anything in her urine dipstick. What are you gonna do?
So I need to ask her for recording a 3 days of bladder diary, and then I'll see how her intake and what is the output fluid.
Okay, this is her bladder diary.
Okay. So in regards of her fluid input and output, it's for me seems to be normal, and she doesn't have any leaks. So I'll consider this bladder diary as a normal finding.
Okay, so what are you gonna do?
So I'll try to ask her to do bladder retraining, and I'll give her the leaflets for that. I'll also refer her for the physiotherapy to help her to do the bladder training.
Okay, so how is bladder training done and for how long?
So usually we do it for 6 weeks, and it's by teaching the patient different techniques to increase the length of time between the feeling to need the feeling between feeling the need to go to the toilet and the voiding or passing urine. And that's done by try to distract her mind by different maneuvers. Like we will tell her, like if she's going uh, like every 1 hour to the toilet, to increase it gradually to like 1 hour and 15 minutes for a week, and then increase gradually to reach like a target of 3 to 4 hours interval. And that can be done by doing something else, reading a book, or trying to finish a movie, or distracting her mind by anything else.
Well, she's still symptomatic. What are you going to do next?
Well, so in that case, we need to start some medications like anticholinergics. We have oxybutynin, tolterodine, and darifenacin, and we need to be sure that she doesn't have any contraindications. Like if she has like acute angle glaucoma or anything like that, we can't use this medication. However, if she is fit for using them, we can start them. We need to instruct her about the side effect, which may be possibly having a dry mouth, and also sometimes constipation, blurred vision, um, tiredness, and fatigue. And we need to tell her to try to drink lots of water, because dry mouth and constipation may also increase her problem. And then we need to give her an appointment in 4 weeks time to see how everything is going. If she responded to this medication, then she can follow up in the clinic every like 1 year.
Okay, she's still symptomatic. What will you do now?
So in that case, I need to refer her for the urodynamic study to see what is the bladder activities, and if anything related to her detrusor muscles.
This is her urodynamics.
Okay, so by looking to these urodynamics, I can't see any detrusor overactivity during her, Valsalva maneuver, and there is no leaks at all. And her detrusor muscles is only contracting during the passing urine. So I consider this urodynamics as a normal study.
Okay, so what's your diagnosis now?
So I believe that she's having sensory urgency.
What does this mean and how will you manage this?
So sensory urgency is like increase in the bladder sensation during the filling phase, and that's make her having more desire to void, and also that's presence in like that's present in absence of UTI or detrusor overactivity. So the management will be mainly lifestyle, and we ask her to reduce weight if her BMI is high, to do daily exercise, reduce her caffeinated drinks, and also stop smoking, avoid lifting heavy objects, and try to do again bladder retraining. And we believe that if a patient is having anorexia nervosa, she may overestimate herself, um, sometimes she feels like she's overweight. That's why we need to train her in behavioral methods, that she has to believe herself that she's not. So we need to do for her some like, you know, psychotherapy and behavioral methods to uh, to tell her that her bladder is working normally. So that can be done by biofeedbacks and also hypnosis and bladder retraining again. And we need to tell her that that can with these methods we showed improvement in around 80% of patients, and that's due to overestimation signals from your brain regarding your bladder. You feel that your bladder is full, however it is not. So usually the biofeedback is to attach some sensors to her, like, you know, like, you know, rectal sensors and abdominal sensors, and that will show her on a computer that her bladder is working normally. So she will have a proof of that. And some psychotherapy and talking therapy and also hypnosis can help in having long intervals between her like, you know, voiding time and also bladder retraining. So there is no rule to do any further medication or MDT or anything.
Thank you.
No problem.